What are the age-related changes that we're going to see in elderly patients? We all know that aging is associated with damage to the mitochondrial and nuclear DNA caused by increased oxidative stress. This also is associated with increased lipid peroxidation, telomerase shortening, altered gene expression, and also with upregulation of cell apoptosis. Collectively, these mechanisms result in alteration in drugs' pharmacokinetics and pharmacodynamics. When we speak about the age-related changes associated with absorption, we can see that physiological alteration with respect to aging involving the GI system includes reduction in the intestinal blood flow, decreased gut motility, delayed gastric emptying, and reduction in gastric acid production. Age-related changes associated with distribution is also seen in adults. With increasing body fat, this leads to prolonged half-life of fat-soluble drugs, for example, diazepam and amitriptyline. Also with aging, we will notice a decrease in body water. This will increase the serum concentration of water-soluble drugs, such as ethanol, digoxin, levodopa, and morphine. What are the changes that is usually associated with aging in the liver? We can see a reduction in size by approximately 25 to 35%, and also decrease in hepatic blood flow of more than or equal to 40%. The drug metabolism in the liver is usually determined by the hepatic blood flow and enzyme activity hepatocytes, which is called the intrinsic clearance. Examples of flow-limited drugs include the propranolol, calcium channel blockers, and the tricyclic antidepressant medications. What about the kidneys? With aging, we can see that there is a decrease in size by about 20 to 30%, increase in fibrosis and tubular atrophy, reduction in renal function significantly affect the elimination of medication such as furosemide and digoxin. And this can be caused by morbidities commonly associated with aging as well. It is always important to bear in mind when we determine correct creatinine levels that serum creatinine alone is not an adequate measure of renal function in the older patients. As patient ages, their muscular masses decreases, giving rise to reduction in creatinine production and a false negative result for assessment of potential kidney impairment. And it is very important to calculate the creatinine clearance either from a urine collection or by using validated equations. Also, it is very important to bear in mind in elderly patients we need always to calculate the renal dose according to the creatinine clearance. And we all know that as creatinine clearance gets lower than 30 to 50 mL per minute, medication dosages need to be significantly adjusted. Example of these medications include the Enalapril, Cephalsporins, and Furosemide. And it is important also to consult with clinical pharmacist or check drug formulary for more information about renal dose adjustment. This table enlists for us the summary of all these changes that we can notice with elderly in the pharmacokinetics of medications. As we mentioned, with absorption, there will be a slightly decreased absorption in general. In distribution, there will be an increased plasma concentration of hydrophilic drugs. In metabolism, usually the first pass metabolism can be less affected, and with excretion, renal elimination of drugs can be impaired. What is pharmacodynamic? They are the changes related to physiological and biochemical effects of the drugs onto the body. And they depend on multiple factors, such as number and affinity of receptors at the site of action, signal transduction, and regulation of hemostasis. What are the cardiovascular changes that we notice in elderly? Usually, there will be a diminished baroreceptor sensitivity, This is most probably due to reduced cardiac muscarinic receptor activity, and this will lead to altered effect of calcium channel blockers. So in elderly hypertensive patients, they usually experience a greater decrease in systolic blood pressure in response to both diltiazem and verapamil. Also, there will be a decreased episodes of rebound tachycardia. Also, what is associated with aging is the decline of beta adrenoceptors sensitivity, and this will lead to reduced effectiveness of beta blockers compared with other antihypertensive agents. We move now to the central nervous system. What are the changes that we notice with aging? There will be an increased sensitivity to central nervous system active medication, such as benzodiazepines, antipsychotics, and antidepressants. And the changes to the central noradrenergic, muscarinic, and serotogenic systems will lead to increased risk and magnitude of many adverse effects related to the central nervous system, such as sedation, extrapyramidal symptoms, arrhythmias, confusion, insomnias, tremor, and xerostomia and constipation. For example, if we take the benzodiazepine, there will be an increased sensitivity to diazepam by usually 2 to 3 folds with aging. There will be an increased sedation and slower reaction time with administration of intravascular midazolam, and there will be an increased sensitivity to these drugs, and it is of a significant clinical implication because usually it can be associated with dementia, falls, and hip fractures. What about opioid? With opioid medications and aging, there will be an increased risk of respiratory depression by usually 2 to 8 folds, and there will be an increased risk for falls and cognitive impairment. Now we move to the drug interaction that we notice with aging. The drug interactions are of paramount importance in patients taking multiple medications, and usually the interaction occur with other drugs, and also it can occur with herbal supplements and food. The association with comorbidity complicates this process, and usually the drugs interact when they have opposing effects, such as the non-steroidal anti-inflammatory drugs and diuretics, or if they have synergistic effects, such as the benzodiazepine and the anticholinergic medications. Many drugs affect the pharmacokinetics of other drugs, particularly those which is metabolized by the hepatic cytochrome P450 system. In a Canadian study which evaluated hospitalization for drug-related adverse effect in geriatric population who had received one of 3 commonly used medications, which are digoxin, glyburide, or ACE inhibitor. In this study, they found that the rate of hospitalization for hypoglycemic episodes was at least 6 times more likely in patients who had received cotrimoxazole. And also they have noticed that digoxin toxicity was 12 times more likely for patients who had been started on clarithromycin. And this can be elaborated in this table, where we can see the association between hospital admission for hypoglycemia and the use of cotrimoxazole. And we can see that there is an almost 6-time increase in this rate of admission associated with the introduction of cotrimoxazole. Also, with digoxin treatment, the digoxin toxicity increased, which necessitated admission to hospital by almost 12 folds in patients who had an addition of clarithromycin in their therapy.